Hello, welcome again. Coming on to the session two of the Retrograde CTO Academy. So today, to start with, I would be discussing how to approach a retrograde CTO case and what is the cautious evaluation of the angiogram and how it helps in planning the case. Because the angiographic evaluation of various collateral of retrograde collateral is very important in the success of this. So, first of all, we have to keep in mind that 70% of the CTO still can be recanalized integrately by use of various tapered wires, microcatheters, wire technique, IVIS guided CTO entry, or knuckle wire technique, or ADR. But there would be 20 to 30% cases that would require a retrograde CTO PCI. And in this, the most of the technique that are used are this retrograde kissing wire technique or marker wire technique, in which the retrograde wire act as a marker to the antegrade wire to cross into the distal true lumen. Another most common, often used technique is reverse cart, and uh, although less commonly used, that is card technique nowadays, but we use the knuckle card technique when the calcium is present in the CTO. And there are few maneuvers required in doing retrograde CTO PCI, that is wire externalization with long wires like 330 centimeter RG3 wires that we will discuss in detail lately, and other maneuvers like tip-in maneuver, reverse tip-in, or a rendezvous technique. So these are the various important salient features of retrograde PCI. Reiterating the various technique in kissing wire techniques, the retrograde wire goes from collateral to the uh, occluded artery, and if it finds ways, it's okay. If it doesn't find, then antegrade wire can be negotiated, seeing the distal wire. This is also called as marker wire technique or kissing wire technique. Second is the retrograde wire crosses itself into the lumen from because the distal end of the CTO is soft as compared to the proximal and the body of the CTO. Card technique, in which a small balloon is inflated on the distal end of the CTO by uh, negotiating this balloon over the collaterals from the opposite artery. Many times it may be successful, but usually not done nowadays. And in this place, if we have a calcified CTO, then of course we can make a knuckle of a wire on the of the retrograde wire, and that can create a subintimal space for the antegrade wire to advance. And most often used technique is the reverse scar technique. In this small balloon, which is called as contemporary reverse scar, in which a small balloon is inflated on the antegrade wire in the subintimal space, and the retrograde wire goes from the lumen to subintimal space to the proximal lumen. So there are fewer different hardware that are used for retrograde PCI. That most commonly contralateral injection is needed. A good collateral identification is very important. Many times short guiding catheters around 90 centimeter are used. Although usually nowadays we can go with the standard guiding catheters, but many operators still use the short guiding catheters. And soft wires are used that are available nowadays, like SUO3, which has a 0.3 gram tip load, or Xion Black, or Xion, or Fielder XTR, that can be used for surfing. And especially this, if it is having a tortuous course or this epicardial collateral, then many times SUO wire would be of much help. And wires to cross the CTO body are almost similar to that of the antegrade CTO wire escalation. We have low to intermediate to high tip load wires. And when the body is very this tough, the CTO body is hard, then we may use this ultimate bros 3 wire, Gaia 2, 3 wire, or many times when we have to go from subintima to lumen, and many times Gladius MG, Gladius Mongo is useful, and especially for the ambiguous course of the CTO. And for externalization, we use R350 or RG350. RG330 centimeter is most common used wire. And we have a good, very good thin profile microcatheters available, like Corsair Pro XS or Caramel. For antigrade CTO, Corsair Pro can be helpful, and the same microcatheter can be used in the form of Corsair Pro XS, which has a further thin profile 1.3 French. I would be discuss about microcatheter wire in a different presentation. So, but just to have a brief introduction about the microcatheter, that what we use commonly are one of the most commonly used catheter in retrograde PCI is nowadays Corset Pro, Access, and Caravel. So for access, there are few studies which suggest that transfemoral can be of more success around 58.2 as compared to 35% as compared to the both transradial access. But nowadays, many operator nowadays take one radial and one femoral that is more comfortable to the operator as well as the patient. So there are few important things that should be kept in mind that while negotiating this, introducing the guide, then the right guide should be hooked first. Then usually we take right femoral with right guide and left femoral for the left guide. And for injection, the donor vessel should be injected first. So this is how, after the angiogram, we should try to make a picture that if it is RCS CTO and how it is filling from the septal collaterals or epicardial collaterals or epimyocardial collateral. So this is how, this is the donor artery, this is the receiving artery, and these are the collateral that are coming from LAD to the distal RCA. So this is how angiogram, so we can take a good injection. So this is showing this ostial to proximal RCA CTO. And from LAD, we can see we have good septal collateral that are filling the PDA. So it's a safe PDA collateral that can be tried to go to the RCA. And as I discussed, this is a failed case, and we have a good interventionist collateral. So this case can be a upfront primary retrograde approach case that should be in our mind. And this case I will discuss later was done with this retrograde approach itself. And once we are analyzing this CTO of LAD, then the collateral from RC should be assessed whether they are septal, whether they are epimyocardial or they are epicardial. In this particular, we are showing that the septals are coming from the PDA and giving the supply to the occluded LAD. So this is a case where we should see that it's a flush occluded ostial LAD and we don't see any flow. And from RCA, which is the post PCI, post stented right coronary artery, giving good collaterals, that is mainly septal collaterals from PD to the RCA. We can see in the two views. We should see this collateral in to see the septals. We should see in the epicranial and RA caudal view to see the origin and to see the course of the collateral, because the entry and the exit point of a collateral is very important while negotiating a wire across these collaterals. So once we have analyzed the collateral, that the things should come into our mind. What are this type of collateral? So Dr. Werner has given a very excellent classification, which is a CC classification. In CC0, we don't find any collateral. There is no continuous connection. In CC1 collateral, that is less than 0.4 millimeter, there is a continuous but a small thread-like connection that are shown in the blue arrows over here, and a continuous collateral that is small sideband like collateral if size is more than 0.4 millimeter, then this is considered as CC2. So CC2 and CC1 collateral are good collateral that can be considered for taking a patient for the retrograde PCI, because this collateral would allow a passage of the wires across them. Of course, the entry and the exit angle, they should not be that acute, because that can cause problem while taking the further hardwares, microcatheters across these collaterals. So in next presentation, next session, I would be discussing each technique one by one, as well as the discussion of the hardware that is being used in the retrograde CTO PCI. Thank you.